So everybody, apologise for those audio problems, and we're just going to kick off again. For those of you that are following the slides via telephone on the slide deck, the PowerPoint presentation, we're up to case studies, and it's case study 1 with Janet. Unfortunately, I don't have the slide number. I can't see the slide number on my screen, but it's case study Janet just before questions. Now, we've got 2 cases here. The first case is Janet. You can see Janet's issues. Relatively stable patient on Suboxone, doing quite well, no significant comorbidities, has some children in her custody, works part-time, and she asks about, is depot treatment suitable for me? I think there's a good example where Janet, she's a busy mum, she's working, she's paying $40 a week, having to juggle takeaways. I think most of us would feel very comfortable with offering Janet the depot treatment. And you can see there, this would really free Janet's sort of daily routine up a lot. You could also argue it actually enhances safety because we're not giving Janet takeaways. And that's to a mum of 2 teenage kids, and we all know what teenage kids do. Teenage kids love going through mum and dad's belongings and taking stuff. That's what teenagers do. So there's the added safety benefit of where you've got children involved, not having takeaways in the picture as well. I think most of us would feel very comfortable with Janet going onto the depot. The other patient is Brian. Now, Brian, 34-year-old, on and off Suboxone for the last 12 months, often misses doses. So you go and look at the dosing, the attendance for dosing, and over the last month, they've effectively missed 18 days out of 30 where they have not had a dose of Suboxone. And we've tried everything. We've tried alternate day dosing so they don't have to Brian doesn't have to come in as often. That doesn't work either. So, and then often what happens when Brian doesn't get his dose of Suboxone, often will use other substances.
I've got it.
Alcohol, benzos, meth, sometimes street Suboxone. So there's this ongoing sort of problem of missing doses, other substance use, often turns up for a dose, has missed multiple doses. Pharmacists or nurses are then sort of assessing the patient for missed doses, and this often causes conflict with staff. Brian's often turning up, sometimes intoxicated, and so what we're often seeing is that we're not doing a lot of case management. It tends to be more crisis management with Brian. So we're so much of the focus literally is just going into getting a dose of Suboxone into Brian. Has been turning up to ED and so forth. Now, this is the kind of patient that when we first started introducing depot treatment, we were thinking, oh no, Brian's not the kind of patient for depot treatment. We kind of were thinking depots are good for the stable patients, the ones that will turn up once a month and we don't need to see in between. And we were thinking that the Brians of the world actually need much more closer monitoring by nurses and doctors, and that somehow we were, seeing this patient regularly all the time and doing all this really productive therapeutic work. Often what we've actually found that with the Brian patients, that we're often just doing, so running around, just really chasing our tail, trying to get doses into patients. And often what many of us clinically have found, that when you put these types of patients onto depots and patients are no longer missing doses, that we actually can engage with these clients much, much more effectively. And these are the patients that often most benefit from entering depot treatment. So patients like Janet, the previous patient, Janet was doing well already, good outcomes, safe treatment. Treatment was working for Janet, and depots made Janet's life more convenient. What we see with the Brians treatment wasn't working particularly well for Brian, and Depo really just increases the ability to keep Brian in treatment without all those missing doses and all the substance use that goes along with it. So generally what we've been sort of suggesting to clinicians, that when you first start using your Depo medication, be it Buvidal or Sublocade, start off with the Janets of the world. Start off with the relatively straightforward patients that are not going to be too complicated or difficult. Get some experience in using the medication, in prescribing it, in injecting it, in handling it, in talking to patients about how you use it. And once you've had a few Janets under your belt, then start thinking about bringing the odd Brian onto the Depo. Because I think many of us have actually found that the Depo treatment makes the greatest difference for the Brians of the world rather than the Janets. But I would recommend pace yourself about how you introduce the medications into your practice. Any questions around sort of those issues before we go into the how do you actually prescribe these drugs? No? All right, let's keep moving. Okay, prescribing Buvidal. There are two pathways onto Buvidal treatment. One is you either come from sublingual buprenorphine or you're not on buprenorphine when you enter treatment. So let's look at the transferring from sublingual buprenorphine. This is pretty straightforward with Buvidal, and the whole principle around Buvidal treatment and the dosing is that dose conversion table you see on that slide. This is the most important slide you will see with Buvidal treatment. So what it does, it gives you the ability to align the patient's daily sublingual dose, which you see on the left-hand side of that table, and according to whatever their daily sublingual dose is, that will tell you what your Buvidal weekly dose should be or your Buvidal monthly dose. So whenever converting between sublingual to Buvidal weekly or Buvidal monthly, this is the table that you base all your prescribing decisions on. So keep this handy, because this is the one thing that sort of allows you to get on with prescribing Buvidal effectively. So what can we do? Any patient on sublingual buprenorphine can transfer directly to Buvidal weekly or monthly. Now, our experience suggests that around 90% of patients, when you use this dose conversion table, around 90% of patients, this is right. This actually works. You don't need to go and adjust doses afterwards. In around 10% of patients, you may need to go and adjust the dose of Buvidal up or down according to the patient experience. And generally what we'll look at what happens if the patient says the dose isn't holding. That's the issue of supplemental doses. Now, if a patient is on sublingual buprenorphine, they can start directly onto a weekly, or they can go directly onto a monthly dose. Our experience suggests that if you have an ambivalent patient that is not sure if the dose is going to hold them, they're really uncertain about this Depo, is it really going to work for a whole month, then I would suggest that those patients think about starting off on the weekly doses. It gets their confidence up that this stuff actually works from one injection to the next, and then once you've had a few weekly doses, then you can transition to the monthly dose. The other patients that we often say go weekly are those patients who actually have a range of other comorbidities, be that physical, psychiatric, social issues, where you still actually want to see the patient fairly regularly for case management, for monitoring other things. So if you want to have that regular contact with the patient, then book them in for their weekly doses, and every week they come in and you can do your therapeutic interventions that way. Now, the other key point to highlight is the supplemental doses. So, say you start a patient on Buvidal weekly, They come back after 3 or 4 days and they say, I don't think it's holding. I'm hanging out. I'm in withdrawal. What do you do about that patient? Well, the model with Buvidal, if that a patient says that the dose isn't holding, the general recommendation is that you top them up with a Buvidal 8 milligram weekly dose. And that you can do that up to a total of 32 milligrams in a week, or up to 160 milligrams in a month. And so say you had a patient on 16 milligrams, they came in after 4 days, they said the dose isn't holding me, I'm hanging out. You look at the patient, yep, they genuinely are in withdrawal, it isn't working for them, or they're experiencing cravings, then you can top them up with an extra 8 milligram, and then you bring them in for when they were scheduled their next weekly dose, and you would give that patient the 16 plus 8, 24 milligrams for their next dose. And you can keep adjusting. Our experience suggests around 10% of patients need supplemental doses, and that almost always is restricted to the first month of treatment. We very rarely ever had to give supplemental top-up doses after the first few injections. So it tended to reflect that we hadn't achieved steady state equilibrium with the Buvidal, and it also tended to reflect that there was also, for some patients, a lot of this is about anxiety that the dose isn't working, when in fact it is. It's just that the patients are a little bit anxious that it may not be working, and sometimes we're just topping them up. Now, the question came before about what's the maximum dose of Buvidal that we can use. The table that you see in front of you reflects what the product is licensed to in the TGA, and generally what we recommend, that usually 128 milligrams is usually adequate for the vast majority of patients. You will see, though, the New South Wales guidelines do suggest that you can go up to 160 milligrams of Buvidal in a month. That reflects the evidence and also clinical experience of using Buvidal, but the 160 milligram injection was not licensed by the TGA. So if you find that a patient is not responding adequately to the top dose of 128 milligrams, then you can go higher. And if you want to bump up the dose to 160, then that is achieved by providing the patient a 64 and a 96 milligram injection. So 2 injections at the same time produces a 160 milligram total dose. In practice, our experience suggests that this is very uncommon. Post-trial, we're sitting at probably only around 5 to 10% of patients need to go up to the 160 milligram Buvidal doses. So I would be surprised, everybody, if you found that you needed to be going often to 160 milligrams, or that you found that the 160 milligrams was not adequate for patients. There will be, no doubt, some patients, we've all seen this, some patients, 200 milligrams of methadone is not enough, 32 milligrams of Suboxone is not enough, and for some patients, 160 milligrams of Buvidal is also not enough. So that's the vast majority of patients, everybody, will be transferring from sublingual buprenorphine. So this is the majority of cases, this will be the slide that you need to apply. Okay, so that's how we transfer. Starting from other opioids. Now, what happened if you had a heroin user or someone coming from oxycodone, for example, short-acting opioids, that turned up and said, look, I don't want to go on Suboxone. I don't want to be on Suboxone. I want to go, I don't like it. I want to go straight onto depot. Can you do straight onto depot with Buvidal? And the answer is yes, you can. This also is off-label. It's not in the TGA product, but it is in the New South Wales guidelines. And what we recommend is that you use Buvidal weekly injections. And generally, the rule of thumb there is, if you know your patient, you are confident the patient has a history of opioid dependence, so you know that they're opioid dependent, you know they have not recently used methadone, you are confident of that because you don't want to get precipitated withdrawal. So there's no recent methadone use, And this is a patient that's had buprenorphine before, and they know that they're not getting horrible side effects to buprenorphine. You know how there's a small group of patients that really do not do well on buprenorphine because of side effects, be it really bad headaches, or some patients get that sort of serotonergic agitation and so forth. It's uncommon, but you know, you don't want to put a depot into a patient only to find that this is the patient that had really horrible headaches, you know, with buprenorphine, and then you find that you're stuck with, you know, 7 days of persistent headache that you can't respond to. So our advice is, if you are confident that the patient is opioid dependent, they've had buprenorphine before, and you're confident that they've got no methadone on board, then you can go in with a 24 milligram Buvidal dose. So that's the recommendation for a heroin user coming into treatment. If you are less confident about the patient, so you don't really know them, you're not confident that they have a long-term history of opioid dependence, you've never seen them before, first time in your practice, and you know, you're not confident that they've had buprenorphine in the past, then for those patients, I would give them a test dose of sublingual buprenorphine. Make sure they're not going to get precipitated withdrawal. Make sure they're not over-sedated on the buprenorphine because they're opioid naive and they're lying to you. And make sure they're not going to get horrible side effects with buprenorphine. So you will see all of that with the test dose. 4 milligrams will do that. It will cause precipitated withdrawal or cause severe side effects in the naive patient. So give them a test dose, wait a couple of hours. If everything's okay, then you can go in with your Buvidal 16 or 24 milligrams. Does that make sense for how to commence a patient directly onto Buvidal? So we go with the Buvidal weekly product, not the monthly product. Our experience tells us that, again, 95% of patients going onto the Buvidal product at the moment are coming via sublingual buprenorphine, and that just reflects we've got this backlog of patients on Suboxone that are interested in Buvidal. And then I just want to highlight what happens with the methadone patient. At this point in time, we're saying methadone patients should transfer to sublingual buprenorphine for 7 days or more and then transfer to Buvidal. There just isn't much experience about going direct from methadone to depot buprenorphine. So at this point in time, we're saying that remains the realm of research, and we shouldn't really be doing that in routine clinical practice at this point in time. So that's Buvidal. Some people like schematics, you know, pictures, and there's a flow diagram if you want to work your way through that about how to do Buvidal dosing. So that's Buvidal, very straightforward in terms of how we use the doses. And again, the principles are that we align the Buvidal dose according to the sublingual buprenorphine dose. And you can adjust weeklies and monthlies according to individual patient needs. Okay, look, I was going to, now, this is very difficult to do in a webinar for people to call out. But what I would suggest to people, when you've got your opportunity, your time to just work through each of these cases, what you do is you get your dose conversion table out and you walk through these. I will, though, I mean, I'll talk through the first couple. Case 1, you've got a patient on 24 milligrams sublingual Suboxone. They want to start Buvidal weekly. What dose would you use? The answer to that is really straightforward. You go back to your dose conversion table, 24 milligrams of sublingual buprenorphine. That aligns to a 32 milligram Buvidal weekly dose. Pretty straightforward. The next patient, case 2, is a patient on 24 milligrams sublingual Suboxone alternate day and wants Buvidal weekly. What dose? Now, that's a bit of a trick question. 24 milligrams alternate day is a 12 milligram daily dose. So the Buvidal weekly dose for that patient is 24 milligrams, not the 32, which is if they're on a daily dose. So pretty straightforward. We have, and you can work through the rest of those and you'll see this pretty, they all follow on from the slides we've been using. Okay, Let's look at SUBLOCADE. SUBLOCADE has a very different approach to the way we prescribe the medication. So in many respects, SUBLOCADE is even simpler to prescribe than Buvidal because you have fewer options. So with SUBLOCADE, remember, we have only monthly products and we have 2 doses, either 300 or 100. Now, to start SUBLOCADE, patients must be on more than 8 milligrams of sublingual buprenorphine for at least 7 days. Sorry, it should be 8 milligrams or more. 8 milligrams or more of Suboxone for at least 7 days before you start SUBLOCADE. And this has to do, remember when we're looking at how much buprenorphine there is in these injections? The SUBLOCADE doses are really quite high doses. So if you've been on a low dose of Suboxone, 2 or 4 milligrams, and you started a patient on SUBLOCADE, you really are increasing that buprenorphine plasma level quite a lot. So the rule of thumb is if you're on low doses of Suboxone, you should probably be thinking about Buvidal. Once you've had some experience, you can go, there are some clinicians who are starting to think about low dose Suboxone patients, for example, on 4 milligrams. Could you start them on 100 milligrams, not the standard 300 milligrams? But that's really, I would suggest, think about that once you've got some experience, and it's off guidelines, so I would suggest talk to a specialist before you did that. The standard model, though, for SUBLOCADE dosing is pretty straightforward, everyone. It's a one-size-fits-all. You start with 300 milligrams for the first dose and then for the second dose. And after those first 2 doses, then you can choose as to whether or not the patient drops down to the 100 milligrams or stays on the 300 milligrams. You can see what happens if the patient stays on the 300 milligrams. The plasma levels continue to go up and up and up and up. Whereas if you drop down to the 100 milligrams, you more or less maintain those plasma levels that you had achieved after 2 doses of 300. So how do you choose about 300 or 100 from the 3rd dose onwards? Well, you start off with 300 for your first 2 doses. You then review the patient. If the patient says, "Doc, this is working really well. I'm not craving. I've got no withdrawals. I'm not using. Everything's just fine. I love this dose. I love the SUBLOCADE." Then you drop the dose. So it's counterintuitive. The patient says the dose is working, so you drop it. Because by dropping your dose, you maintain that same plasma level. If the patient comes back and says after that second dose, "Doc, it's not holding me. I'm still withdrawing, I'm craving, I'm using on top," then for those patients, you maintain the dose. You keep the dose at 300 milligrams because you see that the bupe plasma levels will continue to increase. So it may sound counterintuitive, but you can see the logic behind it. And sometimes you'll need to explain this to a patient why it sounds as though you're not listening. "Doc, this is the right dose for me." And then you respond by saying, "I'm glad we're going to drop it." It sounds counterintuitive, but you have to explain to the patient why you're doing that. Now, remember how with the Buvidal, we said you have flexibility in how often you provide the doses. So the Buvidal weekly, we said, is an injection every 7 days, plus or minus 2 days. And the Buvidal monthly, we said, is a 4-week injection, plus or minus 1 week. So if the patient comes in a little bit early or the patient comes in a little bit late, that's fine. You can still administer the injection. SUBLOCADE also has some flexibility, but with SUBLOCADE, it's less about bringing the dose forward. It tends to, so because it's much higher doses, we don't really bring the dose forward with the SUBLOCADE much. You can see there, we say it's up to 26 days, so you can move it 2 days early. But we're a little bit more flexible with allowing up to 2 weeks late, so up to 14 days after that 28-day 4-week injection. So we sort of say that the SUBLOCADE is like a 4 to 6 week dose, whereas the Buvidal is sort of like a 3 to 5 week dose, if that makes sense. Should you ever need supplemental doses on top of SUBLOCADE? So if a patient was to turn around and say, it's not working, doc, the SUBLOCADE's not holding me, I think I need more, then you don't give supplemental SUBLOCADE booster doses. With SUBLOCADE, you top up with additional sublingual Suboxone. So it's a different model. How often does a patient say the SUBLOCADE isn't working? The answer is very rare. So it's very unusual for us to require top-ups. I would have to say that the services that describe that they've needed top-ups, it tends to maybe happen after there's been a mistake with the administration, a mistake with the injection. So, and that's been the experience on a couple of occasions. Either it wasn't administered subcutaneously, it might have been intradermally. Sometimes we've had problems with some of the actual injections themselves. So, very rarely will you find a patient saying the SUBLOCADE doesn't hold me. It's unusual with the Buvidal. It's even more unusual with the SUBLOCADE. Okay. There's the schematic with the SUBLOCADE. And there's some case studies. Again, some of these are trick questions. So, for example, patient on 24 milligrams of Suboxone, how do you start SUBLOCADE? And the answer is 300 milligrams, because that's what everyone gets. The next case is patient on 8 milligrams Suboxone, how do you start SUBLOCADE? The answer is 300 milligrams, because that's what everyone gets. How do you start the patient on 4 milligrams Suboxone? The answer is you don't. You either put them up to 8 milligrams of Suboxone and say, look, we've got to up your dose, or you offer them Buvidal. And the rest of those cases should be pretty straightforward. And we'll let you work through those because you've all got your slide sets, and it's difficult to do that with 60 people on a Zoom meeting. Okay. Now, administering depot injections. Both of them are subcutaneous. Both of them come in pre-filled syringes. Normally now, this is where I would be showing you the videos. I think we've established that the videos, there's no audio on the Skype call. So what we will do is make sure that you all have the links to the Buvidal and the SUBLOCADE. You can literally Google them, guys, and you'll find them. www.buvidal and www.sublocade. You will find these videos that have been developed by the drug companies. They are definitely worth watching because they will walk you through how to actually administer the two injections. They are slightly different. The key issue with the Buvidal is you have the wider range of options as to where you can administer. So again, upper arm, thighs, buttocks, abdomen. The SUBLOCADE is restricted to the abdomen, and I would, rather than trying to talk you through a video, I would strongly suggest that if you're interested in how to administer these injections, have a look at the videos, and they're pretty good videos, and they're self-explanatory. There's nothing complicated about doing this, guys. They are pretty standard subcut injections, slightly different in their technique. It is fair to say, I think the experience of the SUBLOCADE, many patients will describe that you get a little mass, a little sort of pea-sized or marble-sized little lump that actually is the SUBLOCADE gel forming, and that lump tends to subside over coming weeks. For some patients, it's gone within a week. Other patients say it's still there 4 weeks later when I come in from our next injection. So there's a lot of variability about it. On the whole, it doesn't seem to bother most patients. Some patients do find it a bit of an issue, though, particularly for some of the skinnier patients where there isn't much subcut fat, to be going into. You know, for some of those patients, it can be a bit of an issue. What do you do for those patients with the SUBLOCADE? Well, I mean, you can either the patient tolerates it. The 100 milligram injection is a smaller mass than the 300 milligram. Alternatively, you can tell them, look, it's off-label. We don't normally do this, but buttocks may be a better place to conceal a little mass than the abdomen, so that's an option. It is off-label, but for the life of us, none of us can see any reason why buttocks would be any substantially different to abdomen in terms of subcut absorption. Alternatively, you can, again, Buvidal may be an option for some patients. In terms of which health professionals can administer, nurses and doctors are trained in subcut administration. Pharmacists can also technically administer a subcut. They do need to be trained, is my understanding. And again, watching the DVDs, the videos, and not DVDs, the videos will walk you through the process of administering the injections. There's a lot more, though, guys, to administering depot than simply giving an injection. And we'll come back to that in a moment when we look about the broader issue of integrating treatment. Treatment is not just about jabbing a patient with a drug.
Nick, it's Sandra. There have been a few questions put up. Would you like to...
Yes, please. Do you want to read them out?
Yes, the first one from Gordon. How would you transfer patients from a high-dose oxycontin to Buvidal?
Sorry, how would you transfer patients from a high dose of what, sorry?
Oxycontin. Oxycontin.
Yeah. Generally what I would be doing, guys, until we've all got lots of experience using the depots, what my advice would be, transition that patient onto sublingual buprenorphine the way you normally would, the way the New South Wales guidelines kind of tell you to go and do that. And once the patient's got a few days of sublingual buprenorphine under the belt, then I would transition that patient onto one of the depot products. And you can take your pick, again, Buvidal or the SUBLOCADE. So if in doubt, I would always just go back to sublingual buprenorphine. How do you do the high-dose oxycodone? Well, again, we don't like the long-acting formulations, the slow-release products. We want to avoid precipitated withdrawal with when we start buprenorphine. So it generally tends to mean transition the patient onto a short-acting oxycodone product for a few days. So stop the Targen, stop the OxyContin, put them on the Endone. I shouldn't be using brand names, but you know what I mean. Put them on the short-acting for a few days, and then you can transition them much the same way we would transition a heroin user. If in doubt, don't forget, guys, there's always lots of support you can get. There's DASIS. You can always dial, contact your local specialist clinic. Use DASIS. There's lots of opportunities to be able to get support for those kinds of, generic questions.
Okay, there's a question from John. Would commencement of Buvidal be different with under 18s?
Okay, good. So, look, there's the whole issue around underage consent. And there's the different sort of stages of consent you have at under 16, 16 to 18, and then over 18. In general, if you're ever thinking about treating someone under the age of 16, the general rule of thumb is get a second opinion, document. There's a whole range of issues in establishing, someone under the age of 16 actually has opioid dependence, and you need to do that risk-benefit assessment. Again, for those patients, I would be thinking about initiating those patients on sublingual treatment, and you make the decision, is this working or does this make sense? And then you can transition the patient onto the depot. It's easier to change your mind, to adjust your treatment with sublingual products, short-acting products, than it is with a depot. So with those kinds of should I, shouldn't I questions, remember, the depots are just a different way of getting buprenorphine into a patient. The key questions in someone under the age of 16 is, should I be using buprenorphine at all, rather than which formulation should I be using? So that would be my general approach. Once a patient hits 16, then we're in a different range of issues around informed consent. People over the age of 16 can consent themselves. You don't necessarily need parental consent in that, but we generally will still be recommending get a second opinion when treating people in that 16 to 18 age group.
Nick, it's John here. Thank you. That's really helpful. Some of the people on the training treat adolescents as well as myself. I was more asking whether you'd keep an adolescent, say, who's 17 and has established opiate dependence, whether you'd keep them on weekly Buvidal for longer before switching to monthly, or is it exactly the same as the adults? Sorry, that was the point of my question.
Yeah, look, thank you. Look, it's really interesting. When we started using Buvidal, we were all really anxious. We didn't know what we were doing, not surprisingly. And we kind of thought, oh, look, we'll start everyone on weekly. And our first few months of using the depots, we didn't, our model was everyone starts weekly, and then after a few, generally tend to be like 4 doses of weekly, we then transitioned to monthly. So that was the way we started using these medications, and the patients often were very anxious. These were the first people in New South Wales, and they didn't know what was going on. Is this going to really work or not? So we were all doing baby steps and using the weekly products. Now that you look at the services, they've got more experience in using these products now, and generally what we find, over 50% of patients are starting monthly directly. And this tends to be because we as clinicians are more comfortable going straight to a monthly. We know this stuff works. We know if there's a problem. We know how to, change tack, and top up, however, whatever we have to do. So we are much more comfortable in using the monthlies. And now also patients are talking to each other, and the patients are saying, oh yeah, the monthly works, go straight onto the monthly. So the patients tend to be more comfortable in choosing the monthly option as well. So if in doubt, if you're not comfortable, if you're uncertain, go with the weekly. It's the easy option for initiating treatment. And then you can transition to the monthly as required.
Thank you, that's really helpful.
Okay,
the other patients that we say we love the weeklies are for those patients, as I said before, the ones with multiple comorbidities, the ones with the polysubstance use, the psychiatric issues, the homelessness, blah, 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 all those issues where you're kind of thinking, look, we want the convenience that you don't have to come in every day, but we would like to see you maybe once a week, to just touch base on how these other comorbidities are travelling. Whereas if you put a patient on a monthly, it can be difficult to get that patient back within a month, if you know what I mean.
We have a few more questions, Nick.
Yep, let's go for them now. Yep.
When a patient is early or late, do you maintain the original timeline or start the 4 weeks from the new dosing day?
The beauty of Depot is the flexibility it provides all of us. So you can do whatever you want, quite frankly, whatever makes most sense for your clinics and for your patients. So I'll give you an example. I have a clinic on a Monday in one of the facilities I work in, and so if a patient rocks up on a Tuesday, I can't see them. So and many of you will have similar issues that you're not in your practice every day. And so the patient that, for example, I saw them on a weekly dose, they had to get a top-up, say on the Thursday. They got an 8 milligram Buvidal weekly top-up, supplemental dose, because it wasn't holding. What do you do with that patient? Do you make Thursday the new day, or do you snap them back into the Monday routine? Well, because I'm only around on a Monday, I would snap that patient back into a Monday routine. But if I was also there on a Thursday, I could do either. And I would talk to the patient, I would talk to the clinic staff and say, what do you reckon, guys? What makes most sense? And you can adjust the treatment accordingly. Say the patient is on a, Buvidal 4 weeks plus or minus 1 week. They come in after 3.5 weeks, just say, it's a public holiday, for example, or long weekends, or they're going away for whatever reason. They can't come in on the allocated date. They come in a few days early. When do you say the next one is due? Is it 4 weeks after the last one, or is it 4 weeks plus 1 week? And the answer is whatever you want to do. There's a lot of flexibility in the way we use these medications, which is nice. When we're talking about how we write scripts, I think this is a really important issue. As doctors, if we write the scripts well, it actually gives our nursing staff and the patients a lot of autonomy to make these decisions. So when we get around to looking at how to write a script, we will. I'll come back and give you a few pointers on that.
Okay, next one. Can the preparations be removed if the patient experiences significant pain around the injection site?
Thank you. So can you remove the injections? Now, with the Buvidal, there's sort of nothing to see. There is no obvious lump. So it dissipates in. So it's kind of like you would actually have to go and try to, you would have to, where is it? What am I excising? So in general, there is not really a history or a documentation of surgical removals of Buvidal injections. There have been a handful of cases of SUBLOCADE being surgically removed. These have been reported, I think, in the US. I don't think there's been any cases in Australia of a surgical removal. I could be wrong. And why has that had to happen? I think in the US there was a problem with necrotizing fasciitis or something that happened with an injection. So the answer is, for SUBLOCADE, if necessary, yes, you could. But gee, we don't have a lot of experience doing it. And then the question is, well, who would do that? I would suggest do not get your addiction psychiatrist or your addiction physician to start surgically removing things from patients. I would go and get someone that probably has got a little bit more experience in that kind of surgical technique.
Last question. What is known about withdrawal syndrome from Depo-But?
We'll look at that later on, guys. We'll come back to that question. Okay. We won't do the video clips. We'll pass on those, because again, there's no audio. But I strongly commend everyone, go and have a look at those videos. It will give you a sense on how to handle the medications. They are both special proprietary pre-filled syringes, so it's worthwhile having a look at them in the videos. The other thing, guys, if you want, I am sure that the company the staff from the product people from both Cameras and from Indivior, I'm sure that if you wanted them to come and to walk you through some of their injections and allow you to handle some of their injections in person, I'm sure that they would be very, very happy to oblige. Okay, I'm conscious of the time, so let's keep moving unless there's any strong objections, because there's a couple of issues I just want to touch upon here, and then we'll look at some of the logistics about how we provide treatment. The first issue that I really want everyone to start thinking about is this issue about how do you integrate depot treatment into routine care. And this is something that we've all had to learn this. Early on, all our interest was how do we prescribe the drug, inject the drug, administer the drug, handle the drug. That was our focus. Once we learned how to do that, then we've actually had to start asking ourselves, okay, so the patient now comes in once a month, for example. How do you ensure that treatment is more than just coming in? See, getting jabbed by a nurse in 3 minutes and then seeing their doctor every 3 months. Because I think most of us would say that's not really comprehensive clinical care. That an important aspect to providing good comprehensive opioid treatment, it's not just about the medication, but it's also the care planning, attending to comorbidities, other substance use and so forth. So I think it's really important for us to think through, great, patients aren't turning up every day. How do I make sure that someone is doing that work? Now, initially we were worried, well, is depot treatment going to, are we going to lose the ability to do the psychosocial interventions? Now, I put this slide up because it really highlights this is the New South Wales framework, and you can see there that even our most high treatment needs group, we are recommending that minimum someone should do a proper clinical review of that patient once a month. Now, that corresponds to once a month depot injections. So what I would be strongly recommending that you all start thinking that he or she that administers the depot is probably the person that is in the best position to be doing the case reviews and the case management activities. So we've had to put a lot of focus in our services about thinking through that, it's not just any random nurse that will administer your Buvidal or your Sublocade. Actually, it's come back and see your regular nurse who is your caseworker, and they will be going through all your treatment stuff. And at the end of that, you'll get your jab, you'll get your injection. So we were concerned in the early days that the depot would result in a disconnect between psychosocial care and medication. And so we've had to make sure that that doesn't happen with our patients. Does that make sense for people? And you can also see there that for those patients who you want to see more often for psychosocial reasons, they're the ones that we might just keep on a Buvidal weekly program for a little bit more, for a longer period of time. We've even had some patients who are doing who are doing well on a monthly. Something happens in their life, they become destabilized, and we want to see them more often. And sometimes we bring those patients back to a Buvidal weekly dose. Okay, so I cannot overemphasize how important it is that we don't just think that this is about, administering an injection and that's all we have to do for our patients. Urine drug screens. Now, COVID, I think, has blown routine urine drug screening out of our routine repertoire of skills. But I think we all appreciate that there is a significant role for urine drug screens. A lot of the indications for urine drug screens was often is that we were using it to make clinical decisions around takeaway doses. With depot, there are no takeaway doses. So it means you don't need to do urine drug screens just for the sake of, getting a urine to monitor takeaways. So it actually now means that if you want to do a urine drug screen, go for it, but ask yourself, why am I doing this? It really is, how am I going to use this investigation and how is it going to alter, the treatment I provide my patient? So as often UDSs were just done routinely, linked to patients getting takeaways, now I would suggest ask yourself the question, why do I want a urine? And that's just good, efficient healthcare. There's a range of safety issues. Most of the side effects we've spoken about, local side effects generally tend to be mild and spontaneously resolve. Driving, I think, we're all aware of the concerns around driving and opioid treatment. Buprenorphine tends to be less of an issue than methadone, but patients may still feel, and some patients will describe feeling sedated when they first start their depot treatment. So we generally advise patients that don't drive in the first few days after you first get your first dose of depot. So wait until you've had a few doses, and you can, better gauge what the effect of that medication is having upon you. And generally what we would say, most patients, it's fine to drive on buprenorphine if it's not affecting your driving, and you will generally know by day 2 or 3 after your dose whether or not it's likely to affect your driving. Drug-drug interactions, it's buprenorphine, so the same issues as with other medications. There aren't too many clinically relevant drug-drug interactions with buprenorphine. There are a few, and it's a little bit like liver disease that we see down the bottom. If in doubt, avoid depot products, avoid long-acting products if you've got concerns around safety of buprenorphine in a patient. So if you don't know about, will they get a bad side effect like a headache? Will they get drug-drug interactions? Will the buprenorphine tip them into liver failure? If you're uncertain, I would suggest treat with sublingual buprenorphine. If there's no concerns, then you can transfer them to a depot product. Simply because if something goes wrong, you can turn sublingual treatment off very quickly. If something goes wrong with depot, you're sort of stuck a bit. You can't take it's not easy to take the buprenorphine away, if you know what I mean. Okay, pregnancy. The New South Wales guidelines basically suggest do a risk-benefit assessment. Buprenorphine, whereas once upon a time we used to go on about buprenorphine, the evidence did not support its safety in pregnancy. Those days are long gone. The evidence now from around the world actually suggests that buprenorphine may indeed even be safer than methadone in pregnancy. So we're no longer saying buprenorphine should be the second-line treatment in pregnancy. In many parts around the world, it's actually recommended as the first-line treatment in pregnancy. With the issue around depot treatment, we generally would say do the risk-benefit assessment, have the discussion with your patient around the advantages or disadvantages of depot. Be aware that there is a preservative in both depot formulations that technically is contraindicated in pregnancy at really high doses. Neither product comes even close to achieving those concerns. So yes, it does have this, both products have a preservative that we don't like using in pregnancy, but both products, it is at such a low dose that it's really irrelevant. It's just clinically not a big issue. And then finally, pain management. It's very similar to managing any patient with pain and buprenorphine. Generally you often have to advise our anaesthetists and so forth. You've got a patient who's having elective surgery. What are you going to do with the buprenorphine? The answer is keep buprenorphine going. Do not stop the buprenorphine. Maintain the buprenorphine, and you provide analgesia on top of buprenorphine. And many of us now will have, we know how to do this. You either use non-opioids, either, paracetamol, non-steroidals for mild pain. You can use ketamine for severe pain, or the anaesthetist would if it was a severe acute pain in a hospital setting. You can use just higher doses of routine opioid agonists for acute pain in a hospital. So you can just load up the oxycodone or the hydromorphone or the morphine. You just got to titrate the dose up. Or the other thing that anaesthetists will sometimes do is go and use a super agonist, like a fentanyl product, one that's got a higher affinity for the opiate receptor than even buprenorphine has. But you know what? Those anaesthetists tend to know how to use their drugs. They're often just asking us, what do we do with this depot? And what you just got to say is, look, it's just buprenorphine. Just keep it going, and you provide analgesia on top of the buprenorphine, if that makes sense. Okay, they're the safety issues. And then the other thing I was going to comment, coming off the depots. Now, it's fair to say we don't have a lot of experience, documented experience. There aren't any clinical studies that have been done. All we've got is some anecdotal experience from clinicians who have monitored some patients who have stopped depot treatment. That's all we've got at this point in time. So we're really talking about a handful of cases. And what has been their experience? Well, their experience tends to be very mild withdrawal, and it tends to happen generally somewhere around 1 to 3 months after the last dose. Now, many of us think that the depot treatment should be a really nice way of helping our patients come off opioid agonist treatment. Think about what we generally try to do when we bring patients down off their buprenorphine or their methadone. We taper the dose down gradually over a 4 to 8 week period with buprenorphine. Well, that's essentially what you're doing with a depot. Basically, the drug is doing that itself. So you've got this internal slow taper. The other advantage we like with the depots is that patients have already stopped that connection of, I have to take a pill or a tablet or a drink every day in order to not be sick. Well, with the depot, you've already cut that sort of Pavlovian response. So we think that that should help with the expectancy. And then linked to that is, many of us will know, many patients are absolutely fine until they know the day of their last dose. And on the day of their last dose, even though it might be 0.01 milligrams of methadone, some patients just collapse in a heap because it's the day of their last dose. So that expectancy factor. So we think that the depot should be good. We just don't have much experience yet. Think about it pharmacologically, though. These drugs, think about, again, these drugs slowly wear off. It takes usually around 3 to 5 half-lives for a drug to reach 0 plasma levels. So with the Buvidal, 3 to 5 times 3 weeks, which is the Buvidal monthly half-life, will take you around the 8 to 12 weeks, 8 to 14 weeks, somewhere around there should be when patients actually hit 0 milligrams of buprenorphine. With the SUBLOCADE, it's a longer period of time. You might well be looking at closer to 3 to 6 months after the last dose that the patient will actually hit 0 milligrams of plasma buprenorphine. So it may well be that patients continue to experience mild withdrawal over that period of time. Okay. Look, we've got a whole bunch of case studies that really highlight some of the issues around polysubstance use. Again, many of us were concerned in the early days around, what are we going to do with polysubstance use on top of the depots? The answer is we don't really have to adjust treatment much at all. If anything, the one thing that happens with polysubstance use and the depot, you actually have fewer concerns around patients turning up intoxicated every day, and where the nurse or the pharmacist has to go through that process of, are we going to dose this patient today? Are we dosing them today? So that's just less of an issue with depot because the patient isn't coming back. From a safety perspective, we've had no problems with any concerns. There's been absolutely no concerns with greater risk of overdose on the depot products than what we see with the sublingual products. I won't go through these cases because they're difficult to discuss in a group setting. But what I'm very, very happy, individuals are I'm very, very happy to, if individual clinicians want to pose any questions, please do not hesitate to either. You can email me directly, you can send them through to Sandra, or don't forget our ongoing ways of getting support, things like DASIS, and speak to your local LHD specialist clinic. Okay, I'll skip through those. And let's look at some of the regulatory issues. Regulatory issues. Oh, sorry, go on. Yes, Sandra?
We have one question from Colin.
Yep.
Colin, would you like to ask the question? No, maybe not. It's about a patient who's been transferred to Buvidal and then transferring them back to sublingual.
Ah, yes, thank you.
Put them on the same daily dose that
Thank
you
you.
transferred them from.
Okay, in case people didn't hear that question, how do you do the transfers back to sublingual? Thank you very much. Worth going through. Go back, look at your dosing conversion tables. So generally, have a look at what's going to happen here. Generally, going back and forth, you just follow this guide, but you see there's a range there. So say you had a patient on 96 milligrams of Buvidal monthly. You look up your dose conversion and it says, well, 96 of Buvidal monthly is 12 to 16 of sublingual. So which one do I prescribe? Do I prescribe 12 or do I prescribe 16? Our advice is you go to the lower end. You prescribe 12 milligrams, which is the lower end. Why? Because the Buvidal hasn't stopped working after 4 weeks. There's still Buvidal sloshing around. It's still there, you know, half-life of 21 days. There's still going to be some Buvidal there for another month at least. So generally what we suggest is you go to the lower end of that dosing range in your conversion table, and then you say to the patient, look, there's still Buvidal sloshing around. That will slowly wear off over the coming couple of weeks. As that wears off, we're probably going to have to put your Suboxone dose up. So if you started off with 16 milligrams, the upper end, and then you have to put the dose up as the Buvidal wears off, you sort of got nowhere to go. Well, you do, but you're upping the patient's total buprenorphine levels, which may be fine. That's what you want to do. But if you don't want to up the patient's total buprenorphine levels, then I would suggest go to your lower end of your dose range, review the patient frequently, and then slowly, you know, adjust that sublingual daily dose upwards as the Buvidal wears off. With the SUBLOCADE, where you don't have the dosing ranges, then it's a similar kind of process. Pick a dose. Again, if you're going from the 300 milligrams, remember that SUBLOCADE is sloshing around for a long time. You know, somewhere around 4 to 6 weeks afterwards, I would be introducing Suboxone probably around the 16 milligram range, and then adjusting the dose over coming weeks as the SUBLOCADE wears off. If I was bringing a patient from 100 milligrams, I would probably use a slightly lower sublingual dose of 12 milligrams, something like that. But again, it's pick a dose, review the patient, and titrate according to patient progress. The one thing nice about buprenorphine is that it is a remarkably forgiving drug when it comes to doses. I mean, think about it, guys. We double patients' doses all the time. You know, we go from, 16 milligram daily dose to 32 milligram double dose. It's a very forgiving medication. So don't get too stressed out about, is it 12 or 14? It probably doesn't matter. Just talk confidently, pretend you know what you're doing, review your patients, and adjust the dose accordingly. That's how I got to where I am in life. All right. Regulatory requirements. I think this is really important for us to get a handle. A lot has changed over the last 6 months about what we can do with these medications, and we have finally now settled into the new world order around the depots. So, as of now, in New South Wales, any doctor that has ever been allowed to prescribe buprenorphine for opioid dependence, that means a doctor who has had an authority to prescribe sublingual buprenorphine, will be allowed to prescribe Buvidal or Sublocade. No special training is mandatory, but we recommend that people do the training. And the training can be either a webinar like we've just done tonight, and very soon available on the OTAC website that Sydney University run, there will also be ongoing continuous online training around the depot products. So training will be optional for our doctors, not mandatory. How much depot can you prescribe? Well, depot is really just integrated into your total amount of buprenorphine. So as of a couple of years ago, GPs that have not done the OTAC course, are not accredited, can prescribe up to 20 patients. If you've done your OTAC course, then you can prescribe to more than 20 patients on buprenorphine products. So, remarkably flexible. It's a low threshold to join the club. There's no mandatory training, and all of you, the very fact that you're participating in the webinar tonight means you've done some training. You should know what you're capable of doing. I think the drug companies also do encourage you to walk through their training program. There's both of them have a very simple training program available on the websites. No harm in doing that either. So that's the who can prescribe. We mentioned before who can administer. Now, a doctor can administer subcutaneous injections. Nurses can, and pharmacists can. Once they've pharmacists, I do believe they need to do some training around the depot. Pretty easy to do. Individual patient authorities, again, New South Wales has very progressive approach with this, and we have to thank our colleagues at PAU on this one. Basically, we have a single authority for buprenorphine. So you do not need a separate authority to transfer patients between sublingual and depot bup. You just need one bup authority. In due course, PAU are going to change the authority forms, and there will be some boxes you can tick in the new forms as to which one you're putting the patient on. But until then, you don't. We're using the old forms. You do see that if you're asking for a new form, remember they haven't gone electronic yet. You still got to fax your form in. Although I do think they are going electronic soon, I believe, aren't they? But if you're doing a faxed written form, then just get your pen out and write Buvidal or Sublocade on the permit application. If you've got a permit already, an authority already for a patient for buprenorphine, sublingual, and you're transferring them to a depot, PAU do want to be informed. So they do want a fax just going through saying, hey, PAU, I've got a permit for, Billy Blogs. I'm going to start them up on Buvidal next week. So they just want to know for their records, but it's not a mandatory legislation requirement.
Nick, it's Nadine here. I just wanted to have a question there. Sometimes we get questions from people that already have a permit to maximum 32 milligrams, and when they transfer over to the depot, obviously the maximum dose is higher. Can you just clarify for us what the current recommendation is if we've got an existing permit?
So they don't actually ask you to make any specific changes because again, you're not putting in a permit. And again, look, the 32 milligrams made perfect sense when it was a daily dose and it was a sublingual formulation, and there was only one sublingual buprenorphine formulation. So, for example, there are other buprenorphine products out there, sublingual, that have a different bioavailability. So there is a product called Subsolve that actually is a sublingual product that the milligrams are different to Suboxone. So 24 milligrams of Subsolve equaled 32 milligrams of Suboxone. So look, it was always, that 32 milligrams really reflects Subutex and Suboxone. There is no daily maximum dose when you're using a depot. So generally just write 160 milligrams if you're going to be going for Buvidal, 300 milligrams if you're going to be putting in Sublocade, or again, you can just write 32 milligrams if you're using Suboxone. I mean, generally, I think, when we get a new permit form, I think we'll have those opportunities to be able to, you'll be able to say, well, for Suboxone, it'll be this. If I'm using Buvidal, it'll be the 160. If it's the Sublocade, it'll be the 300. But until then, just write it in. Most of our patients, we start on buprenorphine, sublingual. We've started a few directly on Buvidal. So most patients have already got a permit. Okay. Travels and transfers. This is pretty straightforward, everybody. You do know that, look, it is so much easier with a depot for patients to be able to travel. Look, before, if they went to Queensland for 2 days, you had to go and get those funny scripts. Like it was all that difficulty, and then you had to send patients to organised community pharmacies and so forth. Now, patients on Buvidal and Sublocade, many of them just come and go, and we don't even know that they've gone off to Northern Territory for a week and walked the Kakadu, and they just come back, and they send us some postcards. So again, it's so much easier. There is so fewer requirements for organising transfers and those kinds of things. However, if you're going to be transferring, remember, last dose details is not all you need to communicate anymore. It's not just about last dose details that matter. It's actually future dose details that also really matter when doing your handovers. So, so think about it. You may have a patient on a Sublocade dose. You need to communicate to the clinic they're going to. Their next Sublocade, 300 milligrams, is due on the 3rd of August. It's not just when did they last get a dose that you need to communicate. And the other thing, guys, you cannot supply the depot products to patients to take away. So if they're going to be away for more than, 4, 5, 6 weeks, if they're going to be away, then you either have to organise someone else to take over the depot at the other end, or you're going to have to put them back to a sublingual product and transfer treatment that way. Writing prescriptions. Now, this is another area that's a little bit different to what we've historically done. Historically, with methadone and sublingual buprenorphine, we've actually been writing orders more than technically a prescription. Now, what I mean by that, a prescription must actually specify a whole range of things, a Schedule 8, doctor's name, prescriber number, address, the name of the drug, the dose, the route of administration, so subcutaneous injection. Now, the thing we have to write is the number of doses to be administered. Now, this is where it is so much different to methadone and sublingual buprenorphine. With methadone and Suboxone, we will write a script from the 1st of March to the 30th of April. That does not specify a total amount of product. Think about every time you write a standard morphine or oxycodone script, you write 20 milligrams morphine times 20 tablets. So, and that's what we have to do with these depots. You need to specify, as that sample script says, 24 milligram Buvidal weekly subcut injection to be administered every 7 days plus or minus 2 days times 4 doses. So there's an error in that, by the way. 4 should have been written in words as well as numbers. So that's an example of a learning error that we've put into someone should point out, the 4 doses should have been in words as well as numbers. You're correct. But look at the way we wrote the script there. Every 7 plus or minus 2 days. Likewise, with the Buvidal, monthly, we write 4 plus or minus 1 week. For the Sublocade, generally you write, 28 to 42 days. Why do we do this? We do this because it then provides flexibility to the client and the dosing staff to be able to go and administer the doses within that flexible range without having to go back and get a script off you. If you wrote a Buvidal weekly every 7 days and the patient turned up on the 8th day, the nurse cannot administer that injection because it's said every 7 days. So if you make sure you got that flexibility in your script, and then your nurses won't be hassling you every time a patient is a day early or a day late. Does that make sense for the prescribers? Good-o.
Can I ask one question on that, Dave Richmond? Just with the Sublocade then, 4 weeks plus or minus 2 weeks.
Well, no, Sublocade is minus 2 days to plus 2 weeks. So
right.
Sublocade You can only go 2 days early and up to 2 weeks late.
So we should put a minimum dose interval between injections?
Well, you could do that. Yep. Yep. So again, there's a lot of ways you can write this script to make it a legal script. You know, so the Buvidal weekly, you could say administer every 5 to 9 days. That's legal. You could say every 7 days with a minimum of, well, no, yeah. Well, actually, no, you'd have to specify that 5-day thing, wouldn't you? Yeah. So,
Yeah.
so you can see why we kind of recommend this 7 plus or minus 2 days, 4 weeks plus or minus 1, or, you know, every 4 weeks brackets 26 to 42 days. So it just provides that flexibility without the nurse, you know, complaining that they can't give the injection because the patient's a day early.
Yep. Now,
SUBLOCADE. Remember how we said that if you've got a cold storage fridge, Schedule 8 fridge, SUBLOCADE's really, really simple. Most of us don't have that. So the mechanism of ordering your SUBLOCADE, so what Indivior will do, Indivior will actually supply individual patient doses to the medical practice on request. So there's forms, there's a whole world of setting this up. So if you want to do SUBLOCADE, what we suggest is contact the Indivior reps and they will walk you through the process of how to do this. Because of that 7-day rule, what they will do is they will ensure generally they will aim within a 24-hour turnaround. If you've got Billy turning up on Wednesday to get their 300 milligram dose, as long as you've gotten to the Indivior people before Tuesday and said, I've got Billy turning up on Wednesday, 300 milligrams, you put your form in, they will deliver that 300 milligram dose for Billy to your medical practice or to whoever you've requested it to go to. So if you want to use SUBLOCADE, it's that 7-day out of the fridge which allows you to store it in your medical practice. Otherwise, it would have gotten really complicated. So if you want to do the SUBLOCADE, ring up the Indivior people, and I'm sure they will be very happy to come and talk to you about how they bespoke fit their system to your clinical practice. The Buvidal, it's the same handling. I won't walk through all this. This is the exact same handling as methadone and Suboxone. For Symbion handle the Buvidal, so you order it the same way, you get your methadone supplies. Sorry, sorry, I had another slide. I thought, okay, it's fallen out. The other thing I just wanted to highlight, everybody, now that we're moving to community settings, there are a lot of opportunities and a lot of different models by which we can deliver depot medications. The one thing we don't do is dispense the medication to the patient. That's out of the question. So there are a number of options on how to do this. It is legal in New South Wales that a medical practitioner can store Schedule 8 medications. To do this, you need S8 storage requirements. This is no different to storing Buvidal or SUBLOCADE, is absolutely no different to the requirements for your medical practice to store morphine or any other S8. So if you want to be storing Buvidal in your practice and SUBLOCADE, you can do that. We recommend there's some documentation from PAU with there's sort of a cheat sheet on what you need to do that. So if you're a GP or specialist in private practice, there are no barriers to you becoming essentially like your own pharmacy effectively, i.e. you order the drug from the wholesaler, you get an account with the wholesaler, they deliver the drugs to you, you store the drugs as a Schedule 8 on your premises, you have to handle those drugs. You need, to basically count them in, count them out, all the ways you normally handle Schedule 8 medications. And then a private practitioner can order the drugs in and administer the drugs themselves. A GP could decide to administer the drug themselves. They could think then about how do they get reimbursed for that. They can think about different Medicare items because it does take longer. Alternatively, they may get a practice nurse who can also Medicare to administer the medications and so forth. So there are ways of reimbursing GPs and nurses within a practice to do the additional work associated with handling the depots. Another model might be a community pharmacy, handles the medication. They order the drug in, doctor writes the script, sends it to the pharmacy, which is around the corner from their practice or next door or very close to their practice, and that the pharmacist then delivers the drug to the doctor. And there are many pharmacies that will do that delivery to the medical practitioner. Think about, if you're thinking of that model, you may want to think about, well, I don't need 30 community pharmacies doing this. It's not. So with methadone and Suboxone, we have to find a pharmacy close to where the patient lives. With the depots, it doesn't matter where the patient lives, it's where your practice is. So you may want to think about, do you have a local friendly community pharmacy that you've got a good relationship with that you might want to go and have a chat to the pharmacist? Look, there's this SUBLOCADE, Buvidal stuff. Can we enter in some, arrangement where I send you the script, you handle the medications, you send me the medications? It does raise the issue about how does the pharmacist get paid for their labour, and that's an interesting question that pharmacies and GPs around the country are trying to get their head around how that works in private practice. The other model is you can always think about, if you're a GP and you're thinking, look, I don't really want to do a lot of this. I've got a couple of patients. This might be useful for me. I would suggest talk to your local LHD OTP clinic. They may be interested in doing some kind of a share care arrangement, where you prescribe, but you may get, the patient can go and get their injections at the local public clinic, for example. But talk to your local services. I'm sure most of them would be very happy to enter into some form of discussion.
Nick, there are a couple of questions.
Yep. Well, I think that's about all I was going to present. Actually, no, I think there are just some wind-up slides at the end. One of the things, further support and resources. So again, we've got our guidelines, have a relationship with your local LHD clinic. DASIS, all the DASIS consultants know what they're doing with the depots. So never, don't fail to always remember they're a great resource for clinicians. The drug companies have got some good literature out there, and Newer have also developed some good client resources for consumers. And I think that was going to be it. Oh, yeah, and Sandra and Tanya asked me, please, can everyone complete your workshop evaluation and email it back to Sandra. And on that, there are your references. You've got all those slides. On there, I'm going to go off the slide, off the presenting, and just go back to normal Skype, and let's throw it open up for questions.
Lisa, did you want to ask your question?
Hello?
Yes.
Hi, yes. Is that you, Lisa?
Yes. I'm just asking, as far as nursing care, because the nurses are going to be doing the majority of giving the injections, care plans, things like that, there is really no MBS or no number for the nurse to claim. Have you considered that at all? Because that may be a stumbling block. Spending significant time with a patient, the doctors want to maximise money, and we need to consider that as well.
So look, you're right. Medicare is complicated when it comes to reimbursing nurses. There are some really, well, how will I? very low value Medicare items for practice nurses, for doing minor minor procedures, giving injections. So there is a Medicare item for practice nurses. It's not a particularly,
That's
good
the
one.
10997, which is $10 for 5 visits a year, not one a month.
Yeah, they're not great. There are some mental health. If you're a mental health credentialed nurse, then there's some Medicare items there as part of a plan. But you're right, it does make it challenging for nurses to be reimbursed via Medicare for this. There are other ways that doctors GPs can do this. So again, a GP can, my understanding is a GP can claim a higher Medicare item when other clinicians in their practice have seen the patient. They may have a registrar or a practice nurse. So this is not an unusual thing that happens in multidisciplinary care. But again, I'm not an expert on nurse Medicare items in mainstream practice. I would love to say, I'm going to ring up the Commonwealth Health Minister and suggest a new Medicare item at the moment. They've just done their Medicare review, the Medicare item review. That was a very complicated, long-lasting process where they were trying to reduce the number of Medicare items. We haven't seen the fruits of that labour yet, but I think it's sort of like once in a generation that you get an opportunity to change Medicare items. So I'm not holding my breath thinking that in the next 6 to 12 months we're going to have new Medicare items. The pharmacists have likewise identified this as a real problem. If a pharmacist was to spend considerable time with the patient, not just administering an injection, but also talking to them about, other things going on in their lives, case management type roles, how does the pharmacist get paid for that? Because there is no mechanism at the moment through normal systems.
Hello, it's Corey Pratt. A couple of comments. If you can put them on a GP management plan, and then the reviews are also Medicareable. So you do a review once every 3 months, 6 months, and you've got to be careful not to overservice. But you can give them, you can do a review of their GP management plan, and that becomes your review of your treatment review. That's one way of doing it. My other comment is that if you want to apply to cameras to get an account to deliver directly, you need to prove that you're an accredited prescriber, and I have one, but it's only for accredited prescribers, the delivery to practice.
Yes, that's my understanding, correct. So, so that's the decision that cameras have made, that they will only be providing and I think Indivior have done the same thing, that they will be providing medication to doctors who can use it. So yes, you will need to go through and say, I can prescribe buprenorphine, correct.
Nick, Sandra here, we have some questions. Is the administration point required?
Sorry, Sandra, you're not coming through. If you can speak through to the...
Is the administration point required to be specified on the script?
Sorry, I missed that. Do you have to specify the pharmacy on the script? Is that correct?
Yes. Yes.
So my understanding is that it is not a regulatory requirement to write the name of the pharmacy on methadone or buprenorphine prescription. It is recommended good practice. So what is in regulatory is NES 8, patient name, address, your contact details, as we said before. So it is not legally required that you must write the pharmacy name on the script. It is just very good clinical practice, and especially where you don't hand this script to the patient, this is very much the case where this script goes to a named pharmacy that will be supplying you the drug. So here's a good example. You should never just give a depot script to a patient and say, good luck finding a pharmacy that will dispense this, because no pharmacy can dispense that to the patient.
Okay, the next one. What do you do if a patient is turning up every 21 days for their monthly Buvidal script, which says every 4 weeks plus or minus 1 week?
Sorry, Sandra.
I can probably help you with that, Nick, because Sandra, we can hardly hear you. What do you do if the patient is turning up every 21 days for their monthly Buvidal script, which says 4 weeks plus or minus 1 week?
Yeah, lovely. So it tells you one thing. It probably suggests that maybe put your dose up. It suggests that dose, if it was 96 milligrams, for example, and they're coming in every 21 days, it may well be, well, is that because they just want to come in every 21 days? And there's no reason why you can't say, well, okay, you're a 21-week kind of a patient, 21-day patient. But in most circumstances, you'd be saying, well, it's probably not holding you for the 4 weeks, and whether or not there's a role to up that patient up to 128 milligrams. But again, ask the patient why. Why do you keep turning up every 21 days?
Sorry, there's one more question there. Does the pharmacist have to deliver the Buvidal or Sublocade to the doctor, or can their nurse or reception team receive it on their behalf? And I've confirmed under that the doctor can delegate someone to receive the delivery, and yes, a receptionist or a nurse is okay.
And correct me as I keep saying, as I've said before, tell me if I'm wrong, but the pharmacist can also delegate the delivery to one of their staff members. So there's no reason why you couldn't have a pharmacist dispenses the medication, the delivery team then delivers the medication to the GP practice. The GP receptionist accepts the medication, and that's done pretty streamlined. Yeah. So it's not as though you have to have the pharmacist and the doctor, waiting at the door.
Yep, and I will just mention as well that currently in New South Wales, pharmacists can't give these injections.
Not at all. I thought they were allowed to.
They can give certain vaccines, but at this point they can't give this injection.
Okay, all right. I imagine there will be developments in time with that. I think it's probably pharmacists have never wanted to give an S8 injection, I imagine, in the past. It's just never been part of their business practice. So I think this, new technologies do expose flaws in old procedures, if you know what I mean. So, and I think that's what's happened with the depot. We've identified that there are some things like, what's your maximum dose on a permit. That made perfect sense for methadone and Suboxone. It doesn't really make sense, though, when you're doing Sublocade or Buvidal.
Yeah. One more question. I would like to ask about the cost to the patient. Is there a difference between the doses and the two options, whether there's a health card or no health card, etc.?
So, yeah, look, I should have mentioned that. Yeah, thank you. So these are both on the Section 100 list, which means that the medication is free to the patient. Free to the pharmacy, free to the doctor. So there is no cost to patient or to providers. Of course, the Section 100 does not pay the pharmacist for their labour. There is no dispensing fee with the Section 100. So the pharmacists don't even get the $3 whatever they get as a standard, oxycodone dispensing. So there's another example where the Section 100 works in some circumstances, but here's an example where there is no mechanism at the moment for a community pharmacist to be reimbursed in the provision of depot. So that means that you will see private practitioners, pharmacists and doctors having to identify individual bespoke business plans around, if a pharmacist is going to do this, how do they get paid? Because remember, the patient may not step foot in the pharmacy ever. So it's very difficult to actually get a patient to pay a pharmacist who they've never seen. There will be people that figure out how to do this because it's about business, and you know, people figure out business.
I can't see any questions that I've missed. Does anyone have any further questions?
The one thing I know many same with public clinics, urgent action, no, I can assure you with it on, and no, I can assure you would be okay. Oh yeah, okay. One of the key things, there was a lot of, yeah, someone did raise the issue early on. Do you need to have adrenaline and be ready for an anaphylaxis reaction with the depots? It must be said that when, here in New South Wales, when that was raised, no one anywhere else in the world had even thought of this question, because we went out and asked the Americans, the Europeans, oh, what do you do? And their response was, we've never even thought of it before. So I think what we say is, look, you are giving an injection. With any injection, just like a vaccine, someone's going to be allergic to something. You give enough injections out, someone's going to have an anaphylactic shock. You know, it's just the way it goes. No harm in making sure that if you're in the business of injecting people with medications, no harm in just making sure that you have anaphylaxis, a procedure to be able to respond to anaphylaxis. Finally, if there are GPs out there, they're thinking, look, I like the sound of this depot. I think there's patients that could work on this, but where they may have some concerns around, but I don't really understand the business model. I've only got 2 patients. I don't really want to go and set up an account and put a safe in my practice and all that kind of stuff. What I'd be suggesting is pick up the phone, talk to your local LHD, and I would suggest that chances are that they'll be very, very keen to look at how you might just be able to get some initial experience, initial exposure in prescribing this to your patients, working in collaboration with your LHD, and then gives you an opportunity to, you know, try before you buy, give it a go. If you like it and you think, yep, I'm keen to keep doing more of this, then you can start thinking about a business model that will, you know, allow you to do this efficiently and effectively.
And I'd add as well to have a chat to PRU, the Pharmaceutical Regulatory Unit at the Ministry, because they can often explain the regulations around storage and delivery and that sort of thing in a way that helps you realise that there are ways that it can be done in primary practice.
Great. It's gone after 8 o'clock. We just started a few minutes late, so we're stuck on time, but it is still coming up to time. I'd like to thank you all. Thanks all for bearing with us for some of the technology issues. It's always a challenge when we're trying to do videos as well. Sandra, please do not hesitate to contact Sandra with any questions you might have. Links to some of the websites and videos, and most importantly, the evaluation forms. Sandra knows who you are, she knows where you live, and she will chase you up until we get that evaluation form back. Okay, Tanya or Sandra, do either of you any last minute?
No, all good from me.
No.
All right. Thank you. Like we said, we expect the OTAC course to be online very, very soon. So if you've got colleagues who couldn't make it into this one, want to do more, get future training, then we will, hopefully that should be going live very, very soon, and we'll be bridging over to that ongoing training platform. So look, thank you all very much. It's really exciting that we've got the depots. It's not not often that we get a new medication to treat opioid treatment, and I think that many of you will, will just get to see just how big a change this can make for the lives of many of our patients. And the satisfaction, it's really nice being able to offer patients something new that really makes a big difference and big change in the day-to-day quality of their lives. So on that note, look, thank you all very much, and
thank you, Nick.
No doubt see you all again.